Hi, my name is Chris Robinson. I'm an assistant professor of neurology and neurosurgery at the University of Florida. And I've been asked to talk to you today about neurologic manifestations of COVID-19. As time has progressed over the last month or so, significant amount of research and reports have come out about other systemic manifestations of the COVID-19 illness. The primary focus, understandably, was the severe acute respiratory syndrome that was occurring. But as each day goes by, either anecdotally or in case reports, we're starting to get information that patients are having neurologic manifestations from this disease. We know by looking at the different populations affected by this virus, not only in our country but around the world, that there seems to be significant heterogeneity within certain groups of people with either comorbidities or underlying conditions. And that probably holds true for those that will present with neurologic manifestations. So what we know thus far is based on anecdotal reports, what I'm hearing from my colleagues, what you might be experiencing in your institution, and some case reports that have been reported on the manifestations, at least neurologically, that have been seen in patients with COVID. Before we talk about that, I'd like to look to the past for a second, because I think in a time of such as this, where information is coming out left and right, I think lessons from the past are important in anything, whether we're discussing clinical care or history in general. So if we look back at the Sars outbreak from 2002. SARS itself was also a beta coronavirus. Beta coronaviruses were discovered in 1952. And they're the most prevalent form of coronaviruses that infect both mammals and birds. If you look at the similarity between the SARS coronavirus 1 and SARS-CoV-2 of today, there's about an 85 to 90% similarity between the viral structure of the two illnesses. We know that both of these originated in bat species, and so I think it's important to see what we found and what we investigated in a peer-reviewed manner in the past in relation to SARS. So there were multiple reports published about neurologic manifestation in SARS with a wide range of clinical diagnoses, including encephalitis, Guillain-Barré syndrome, acute disseminated encephalomyelitis, seizures, and notably critical illness neuromyopathy. And from the SARS outbreak, the hypothesis was that direct neural evasion was occurring with the virus, and that was actually proven in a preclinical study in rats that the SARS coronavirus 1 actually invaded the axons of nerve terminals and caused the weakness. So using that evidence, we have to attempt to figure out what we'll see moving forward. It's important to know that coronaviruses have a significant amount of neurotropism. They have several routes by which they can directly invade the brain and the brain stem. And not only that, the systemic inflammatory response that results from a systemic infection or viremia can result in cytokine storms that allow for blood-brain barrier breakdown and either penetration of the virus itself or penetration of cytokines, resulting in multiple neurologic problems. So the neurotropism of coronaviruses in general usually occurs in one of three routes. One we have seen a lot in the news and within the literature is the retrograde axonal transport that occurs through the olfactory nerve. That's been well studied and shown to actually occur. They took patients with the SARS virus in 2002 at autopsy and found the coronavirus within the oligodendrocytes in the brain. Another mechanism by which the virus enters the CNS is through transcellular mechanisms in which they use host cells like phagocytes to cross the blood-brain barrier. And the third is a paracellular route in which they cross tight junctions of the blood-brain barrier. And in the fourth part that we discussed earlier, which I think is important when it comes to neurotropism or neural invasion, is this cytokine storm that we're seeing with COVID and that perhaps the breakdown of the matrix metalloproteases at the blood-brain barrier is allowing the virus itself to get into the brain, but also allowing for inflammatory cytokines to enter. So the first report that we have for COVID-19 related neurologic manifestations came out of Wuhan about 4 weeks ago. In this study, they looked at 214 patients diagnosed with COVID. They did not randomize them to severity. They took 214 patients, all comers. They found that 36% of the patients had neurologic manifestations. Now, the myriad of manifestations they described in the paper range from headache all the way to more severe illness like stroke and encephalitis. But what was interesting in the case is that they found patients that actually had neurologic manifestations, severe form of COVID, requiring ICU care and or the patients of that cohort suffered from stroke. 6% of the patients suffered from encephalitis, and upwards of 10% suffered from neuromyopathy. You know, this follows suit with what was reported in SARS, and it also follows suit, at least personally, with some of the anecdotal reports that I'm getting from colleagues around the country that a significant proportion of their patients following acute illness and on the way to recovery are having significant diffuse weakness. I think when we talk about neurologic manifestations in general, but specifically related to a viral infection, I think we need to put them into groups. So I think looking at COVID, there's three scenarios that we need to consider. One being acute infection, in which there's direct neural virus affecting the brain itself or affecting the brainstem itself. The second group would be a para-infectious group, in which either the virus itself or cytokines related to the inflammatory reaction from the acute infection are causing a pathology. And then third, a post-infectious route in which antibodies either to the virus itself or antibodies developed due to an overvamped immune system can cause secondary neurologic pathology. When we break these groups down, I think we can get into some of the specifics that we've seen in the literature and some of the reports that are out there currently. So to start talking about the acute infection, COVID-19 is an illness related to coronavirus infection. The coronavirus type 2 that we're talking about directly targets cell surface receptors in the lungs called ACE2 receptors. That's well known, that's being studied, and we're looking further into that. It should also be stated that ACE2 receptors exist in the brainstem, and they also exist in the supratentorial cortex. And pathology reports from the Sars outbreak confirm this. So in the acute phase of illness, we can see things that have been commonly reported, like loss of taste, loss of smell. We've seen, there's a recent paper about seizures that I'll talk about. But specifically to the common symptoms of loss of taste and smell, looking at past pathologic reports, and it's that the virus itself, through direct neural invasion, targets the nucleus in the brainstem, nucleus tractus solitarius in the brainstem, and is the source by which we lose our ability to taste. The loss of smell is theorized with direct retrograde axonal transport through the olfactory nerve, and there's some pretty good evidence for that. There's another paper out of Wuhan that suggests that targeting of the ACE2 receptors in the brainstem, which also exist in the dorsal respiratory group, might be playing a role in pathogenesis related to respiratory sequelae with COVID-19. Other acute manifestations that we've seen that have been reported so far in the literature, there's a patient out of Detroit that was reported to have acute necrotizing encephalitis that presented primarily with confusion and only developed respiratory symptoms days later. There are multiple anecdotal reports of patients presenting without any respiratory sequelae and an encephalitis or altered mental status like confusion. Related to that, the last question is can it directly cause cortical damage and seizures? Now, A paper was published out of Wuhan again over the last few days, stating that acute symptomatic seizures were not seen in patients with COVID. If you dive into the paper a little more, it's a retrospective review, and none of the patients were monitored on EEG. So though the definition of acute symptomatic seizure does include clinical and subclinical seizures, none of the patients in this study had an acute clinical seizure. To say that no one had a subclinical symptomatic seizure, given the fact that no one was monitored on EEG, goes against what most of us think could be happening in these patients. The next group of patients that we talk about are para-infectious in and around the infection, and could be related to both primary and secondary sequelae of the virus, but we just don't have the information to determine that yet. So we can make some observations and make some hypotheses related to this. So early in March, there was a letter sent to Neurology Today from a group of Italian neurologists stating that they'd seen a significant increase in the number of vascular events in their COVID patients. They described significant increase in large vessel occlusions and arterial thromboses in their patients. As our numbers have started to grow in the United States, there's been significant discussion and anecdotal evidence that these patients become hypercoagulable, not only from the venous side, but from the arterial side as well. There's a paper published in New England Journal discussing the development of antiphospholipid antibodies in a subset of 3 patients, and multiple reports that both arterial and venous hypercoagulable states are existing despite the use of anticoagulation. And so stroke is most certainly an increased risk. Now, whether this is due to the direct viral modification of the coagulation system and inflammatory hypercoagulability, we just don't know, but we know this is something that increases patients' risks for stroke. A paper published yesterday also stated that patients who have a previous history of stroke that present with COVID have a 2.5 times increased risk of death in COVID severity based on those that have not had a history of stroke. So I think this area is up for debate. We do know that the patients are getting hypercoagulable. We know the arterial and venous sequelae that could result from such problems. And in fact, a discussion with a colleague recently in New York stated that they had a patient who presented with hypoxemic respiratory failure, but on clinical exam was brain dead. A CT scan showed loss of rare white junction and diffuse cerebral edema. Though the family decided to withdraw care, the underlying diagnosis wasn't completely discovered, but one could assume that perhaps venous thromboembolism within the brain itself or venous sinus thrombosis could have been a culprit in this situation. The last group I want to talk about, which is important not only for neurointensivists, but I think for neurologists down the road, and is starting to gain some traction in the literature, is the post-infectious neurologic manifestations of COVID. So several reports recently of Guillain-Barré syndrome, Miller-Fisher Guillain-Barré syndrome, polyneuritis cranialis, and neuromyopathy. And these reports are coming out more and more every day. And I think if we look at SARS in 2002, there's a significant proportion of patients that also presented with Guillain-Barré. And these acute post-infectious inflammatory neuropathies, if you will, I think are something that would be prevalent and needs to be studied as they come. The reports thus far show that the patients receive the standard care that we provide patients with Guillain-Barré, and they improve with IVIG. So that's encouraging, though I should caution you that the data thus far for IVIG in COVID-19 related respiratory failure has not proven to be fruitful. So the last thing to think about here, and I guess the biggest concern that we have as neurologists and neurointensivists, is what to do about these manifestations, how to discover these manifestations, and where do we go moving forward. My biggest concern with these patients is, given the lack of PPE, the restrictions, the geographic locations of these patients, how are we supposed to examine these patients and ensure that we have a good neurologic examination in lieu of all the other critical care needs that the patient needs. And I think that's going to prove difficult. I have a concern that we might be missing some of these things based on the limitations of not only patient care, but protection from spreading the virus itself. I think something that could be thought about, something that could be encouraged based on the seizure study that I discussed earlier, was perhaps considering a minimal montage EEG monitoring system on patients with COVID-19, at least those with severe illness, to see if we can gain any objective data related to their illness and whether neurologic manifestations are occurring. Limited montage EEG is gaining favor in the neurocritical care world, and it's a safe procedure that doesn't require a tech and a nurse can place on the patient. I think it would be beneficial. We could see asymmetry from left to right. We could see signal dropout in certain areas of the brain that could lead us into clinical questioning related to perhaps underlying neurologic problems that the patient might be having. The last point to think about is the use of steroids in these patients. There's been a lot of traction again as to whether or not steroids are beneficial in these patients, when steroids should be used in these patients, whether we should target inflammatory numbers. And this can pose a problem potentially when we're treating some of our patients with neurologic manifestations. And so the evidence hasn't proven one way or the other. There is a paper currently under review that talks about no improvement in mortality with steroids in respiratory COVID-19, but it did not increase, all-cause mortality in those patients. So one could assume at this point, with the evidence that we have, that steroids might be okay to be administered in patients with neurologic illness. This is an ever-evolving topic. I think we're going to see more and more reports of neurologic manifestations of COVID-19, whether in the acute or post-infectious phase. And I think it's important that we remain hypervigilant and that we understand that this virus can cause neurologic problems, and we need to figure a way out to better evaluate and protect patients from the secondary sequelae that they might have. Thank you for your time. I appreciate it.